Hi, my name is Jake Noble, and I'm a current PGY1 HSPAL resident at Mayo Clinic. Today, we'll be talking about timing tactics, a comparative analysis of prophylactic medication administration on taxane medication infusion reactions. Infusion reactions are defined as a hypersensitivity reaction to specific drugs that are predictable in individual patients and unrelated to the known side effects of a medication. The two types of reactions that infusions can cause are one, an allergic reaction to a foreign protein, or IgE-mediated allergic responses, classified as a type 1 hypersensitivity response, or two, a non-IgE-mediated reaction, also known as anaphylactoid. Most chemotherapeutic agents are IgE-mediated and are true allergic type 1 hypersensitivities. Frequency of infusion reactions to all medications in the general population is something that is difficult to quantify. One antineoplastic class that is known to have a higher incidence of reported infusion and hypersensitivity reactions are the taxanes, paclitaxel and docetaxel. These medications are widely used in the treatment of several types of cancers and are approved as the first-line setting for numerous malignancies. For the taxanes, nearly 75% of all reactions occur during the first or second infusion. With reactions occurring rapidly, it is estimated that 80% of patients who develop symptoms do so within the first 10 minutes of the infusion. Despite pre-medication, incidence of infusion reactions associated with taxanes has been reported to be 10% with paclitaxel and 5% for docetaxel. The taxanes are a poorly soluble molecule. Therefore, they require emulsifying agents so that the medication can be administered intravenously. Cremophor for paclitaxel and polysorbate 80 for docetaxel. The emulsifying agents demonstrate the capability of causing complement activation in vitro. Thus, it is hypothesized that through the production of anaphylactoxins, these agents could trigger immediate hypersensitivity reactions. Protocols that have been implemented to assist in reducing infusion reactions for the taxanes include pre-medications, which include H1 and H2 antihistamines, corticosteroids, montelukast, or aspirin, and the utilization, after all avenues have failed, of desensitization. At this current time, there are very few studies that assess the timing of pre-medications and their impact on chemotherapeutic infusion reactions. Due to the limited body of evidence and practical experiences amongst our research team, we set out to investigate this further. This study aims to investigate the effects of timing of prophylactic medication administration on taxanes at Mayo Clinic, compare the rate of infusion reaction occurrence, and evaluate the impact of pre-medications on the severity of infusion reactions. We are conducting a multi-site, single healthcare system retrospective evaluative study. Evaluating patients from Minnesota, Arizona, and Florida, our inclusion criteria encapsulates individuals who have received their first or second paclitaxel or docetaxel infusion at the Mayo Clinic enterprise. The exclusion criteria for this study includes patients enrolled in clinical trials, individuals less than 3 months between oncology regimens, and individuals who have received a dose of dexamethasone a day before infusion. All data was acquired utilizing an EPIC slicer-dicer report in which our team collaborated with the Mayo Informatics Department to create a new filter to assist with the data that was collected for this project. Measurements such as infusion completion, infusion reaction verification, and the total time an infusion was paused were collected through manual chart review. For our analysis of the data, which is currently underway, the association between the timing of pre-medications were given and having an infusion reaction will be assessed using a spline plot and a cut point analysis to try and distinguish risk groups. Comparisons will be made between groups using chi-square tests for categorical data and ANOVA or Kruskal-Wallis tests for continuous data. Lastly, multivariable logistical regression will be utilized to assess the association between the timing of pre-medications and having an infusion reaction after adjusting for other patient and clinical characteristics. With our analysis of the data still underway, we wanted to showcase the demographics and preliminary trends that we have seen thus far. For the population who had infusion reactions to docetaxel or paclitaxel that are included in our study, their demographics are as follows. For patients who had an infusion reaction to docetaxel, approximately 45% were male and 55% were female. The average age of the participant was 58 years old, and 97% had a grade 2 infusion reaction. For individuals who had an infusion reaction to docetaxel, the average taxane concentration was 0.499. For patients who had an infusion reaction to paclitaxel, 21% were male and 79% were female. The average age was 61 years old, and 88% of the patients that had an infusion reaction were at a grade 2. The paclitaxel concentration on average in which a patient had a reaction was 0.593. One interesting preliminary trend that we would like to showcase from our data is that a large portion of patients have been able to finish the taxane infusion after having an infusion reaction and receiving rescue medications. While we are unsure at this time why patients are able to tolerate a complete infusion after having a reaction, two hypotheses are being investigated through our analysis. The first is if the institutional protocol timing of premedication is being followed by our nursing staff. The second is if there is a potential that the premedications are not having enough time to have a systemic effect within our body prior to the administration of a taxane infusion. From what we have investigated, 95% of patients receiving docetaxel were able to finish their infusion after pausing the infusion, administering rescue medications, and giving time for them to take effect. Approximately 85% of patients receiving paclitaxel were able to finish their infusion using the same method. While we are unsure about why this is occurring, if premedication timing has a significant role in taxane infusion reaction, it could help shed light on a way to significantly increase patient safety. This research project has the potential to positively impact patient care by potentially helping to determine optimal premedication timing, establishing strong protocols for our nursing colleagues, decreasing future patient infusion reactions, and increasing the opportunity for us to help other patients by being able to have more infusion chair time. I would like to highlight and say a big thank you to my wonderful research team. Without their help and support, this opportunity could not be possible. Thank you for listening to my presentation today. If you have any questions, please do not hesitate to reach out. Thank you.